Okay. Posterior fossa tumors are the commonest primary intracranial tumors in children. Most of them, about 2/3 of the pediatric brain tumors that occurs at the site. After surgery, depends on what literature or the more numbers you quote, we're looking at about up to 1/3 of the patients will develop mutism or loss of speech. There's a latency period between 2 to 7 days. The duration can last from a few days or a few months. Eventually, the speech will return, but unfortunately, they never go back to normal. There are lots of research in this field, and from how best to define it, how best to measure the severity, look at the risk factors, how best to treat or to support patients. And in Nottingham, especially in the project I worked on, was specifically interested to develop a simple imaging-based pre-operative risk assessment tool. We tried to identify and separate the patients at low, intermediate, or high risk of developing the surgical complications. We hope that this risk assessment tool will inform the surgical consent procedure and enhance the decision making. So I'm not going to show you a short video, because I'm not going to talk a lot about anatomy or hypothesis mechanism. So I'm going to come in from a slightly different angle, listen to how the CMS, this condition, impact on patients, their families, and a few words from our research team members, see how they feel about CMS to separate those low risk and high risk patients. And so the next question we should ask ourselves is, what's the literature evidence and what data do we need to collect? I think Rob Deneen, our radiologist, mentioned it briefly in the videos. Currently, this is a systematic review published in 2014. You can see a long list of risk factors being discussed or published, but the only thing that constantly showing the effect was tumor location and certain type of tumor, that's medulloblastoma here, and the invading brainstem. So instead, so on top of these confirmed risk factors, we expanded our search, go through different hypotheses. So we put together a much longer list. So these are the things we worked with our collaborators in Alderhead Hospital in Liverpool. So we put together 89 patients who underwent surgery and reviewed their scans and their clinical notes and put together those information. That includes the non-imaging features, that's age and gender, primary tumor location, some non-anatomical features like tumor type. And also, we've put more weight on this thing, that's the anatomical features. That means that whether the tumors invaded or compressed into these structures. I think the problem is the complexity comes in because tumor location and tumor type are highly correlated. And sometimes you have a tumor arise from certain location more likely to affect or invade into nearby structures. And so I think it is not the best, to look at them individually is not the best strategy. You really need to put them together and construct a model if you want to separate the low risk from high risk patients. That's one thing. And the other thing is we are going to develop a risk stratification tool for clinicians. So we need to speak to clinicians. We spoke to clinicians, see what sort of models they want. There are various ways to develop it. And the conventional ways in which we compare the case with non-cases, compare their profiles, see whether tumors at this site or with certain features are more likely to develop it. That's one way of doing that. And we can, based on literature, say there was a hypothesis or there's a pathways behind this. That could be another way. And more recently, people start to use machine learning or the data-driven approach. That means given no assumption, we push everything through the computer and let the computers find out what's the best predictive model. They both have strengths and limitations, especially for machine learning. It may come up with a model that can predict the outcome very well, but clinically it doesn't make sense. Because they're looking for a pattern, an association, not necessarily a causal mechanism. So I think we spoke to the clinician. They would prefer to have something with something converted into a risk factor, so a checklist that can tick. And they will prefer something that clinically makes sense. So they will buy in. If we want to roll it out and promote it, the clinical community will feel more comfortable with it. So the way we structure the model is we started a very long list, as I've shown this out, over 20 variables. We use different techniques, the conventional way and the machine learning way, to shortlist them down to about 10. Then we push it through logistic regression. That's the standard way we use for structuring the prediction model. So we published our preliminary model based on the 89 patients from 2 centers earlier this year. So these are the these are the variables, the predictors we selected. So you can see this mainly primary tumor location and whether the tumors invaded or compressed into nearby structures and the age is there. In that model, based on the 89 patients, we felt that we have about the accuracy is about 88%, and we felt that we managed to pull them into low, intermediate, and high risk. And for high risk, we're looking at greater than 50%, where the clinicians feel it's more likely to happen than not. So that's the cutoff we chose. But again, this is based on 2 centers, so naturally the next step is we want to further assess or evaluate this model in a multi-center setting, see if this thing still applies when we roll out. Okay, so we organized a CMS workshop last year and invited 11 centers from North American and some European countries, and these are the list of centers to take part in the workshop. We asked all centers to submit the most recent 30 posterior fossa cases, including their CMS outcome, and submit this pre-operative scan set. We also asked centers to provide a surgical statement because different centers may have different equipment, different facilities, different ways they want to conduct their surgical procedures. So that is part of the workshop discussion. So this is just a short list of all the inclusion and exclusion criteria. So during the workshop, this is our radiologist, Dr. Rob Deneen. We have an intense discussion to communicate with the centers, the radiologists and the surgeons, how we want to define these imaging features, what do we mean by invaded or compressed, and how do we code these variables in greater details. And after that, we form a small groups. So you will have oncologists, surgeons, and radiologists. This is similar to the MDT settings in day in and day out. They make a group decision, they review it together. So we collect all the information. They ask them to review 30 cases, their own 30 cases during the workshop. So this is the cohort we put together. The first thing that struck me is the CMS rate is much lower than what I expected, because from the first set, that based on the 2 center, we're looking at about 30%, which is similar to literature reported or what the parents just quoted. And in this set, CMS rate is much lower, looking at about 16%. But if you look at the risk factors, I think there's nothing surprising. Certain histology tumor types or MRI suspected tumor type, that's before the surgery because you don't get histology report till after the surgery. So based on the imaging, they can predict. The radiologist would say, we feel this is more likely to be ependymoma, medulloblastoma, or polycystic astrocytoma. We'd also ask them to identify the primary tumor location. 2 things I wanted to point out. But medulloblastoma historically been reported many times, one of the confirmed risk factors, but not so about ependymoma. So in this cohort, and the same as the previous cohort, we see an increased risk for ependymoma patients. And we feel it's probably because it's less common. So if you base on a single center, a very small population, you don't see it. Okay, and secondly is tumor arises from cerebellar hemisphere. So you can see no patients develop CMS in this group. Okay. And this is the second time we see the same pattern. The previous set, we had 33 patients, and none of them developed CMS either. I know it's reported in the literature very incomplete, but we certainly didn't see anything within the 100 cases we go through in 2 cohorts. one thing we set out to do, because the literature review told us that one of the big problems is we don't have large-scale studies. So this is one of the bigger collections we can have, and we can certainly see there's a huge center variation. So I removed the center label. But you can see the range from 8% up to about 20%. That's a huge difference. But we need to ask ourselves whether this is a true association. Sometimes it could be down to it's really good, they manage the risk very well. Or it could well be the case makeup. And certainly in this country, we take all comers, we have catchment areas. But some countries, especially in North America, they will have a slightly different system. Sometimes they will self-sponsor and travel to a different centers, ask for surgery. That means patient defaults need to be healthier or fitter to travel that long distance to that centers. That could be part of it. And by only comparing the crude CMS rate, we won't say it. So that's something we need to bear in mind when we review the literature. Okay, then we recoded all our imaging data into binary and tried to see how well our predictive model works. First of all, if we look at the cutoff, it's roughly about a third for low, intermediate, and high risk. So we seem to think have a very, visually, I think you can have 3 groups. It's very low risk, and something around here, and much higher risk, slightly higher risk at the plot here. Unfortunately, we didn't see that over 50%, which we expected to see. And I will talk about a few reasons we think it would be. But the thing is, if we can pull out the low risk, rather than identify the super high risk, if we can pull out the low risk group, we reinforce the surgeon's confidence in those established surgical approach when we go for, aim for complete resection. And as patients, your risk is no longer what's quoted as 1 in 3. If you have such low-risk tumor type, you actually have very small chance of developing CMS after surgery. And that will help, we think, in terms of taking consent. Okay, there's some issues when we try to upgrade from the experience based on 2 centers down to 11 centers. One thing we need to really think about is the inter-observer agreement. Because we asked the radiologist to sit down and review the scans. And some structures, especially the deeper, smaller structures, if we base on a piece of paper or a definition or even a short presentation, you may have different views than I do. So the way to tackle it, some of the cases must be, probably, I can't say that for sure, there might be misclassification. So they were put down to this end rather than that end. So I think inter-observer agreement is something we certainly need to focus on if we want to roll it out at multi-center level. There are various ways to improve it. We can develop an online education modules, train them and test them before they actually go out to code the variables. And we can perhaps at data collection level use visual aid to say, is what you're seeing now closer to this one, or this one? That will help them to put them into the right category. At least they're trying to code in a more consistent way. Or we can certainly go out and talk to people and communicate better in this way with our presentations. And the other thing I want to point out is for this patient falls into this and intermediate and high risk group, what we're interested in or the focus shouldn't be how accurate we can predict the outcome. Because these are pre-operative risk. It will certainly interact with surgical intervention. And our ultimate aim is to reduce CMS risk. So if there is interaction, we really need to look into it. And do we have a scope? There's a potential to look into it. Yes, we do, I think. Again, this is all the high-risk patients that's on the right-hand side. If you break it down by center, you can see there's actually a gradient. You have centers who manage it probably quite well after 22%, that's about 1 in 5, and centers at higher risk, about 50%. So we can certainly learn from the winners what equipment they use, what technique they use. I think it's up to the surgeons or the clinical community to discuss and trial and learn from each other. But unless we have international comparison and big collection, we won't be able to do it. Okay, the other thing is probably some of you have already spotted, we have 3 centers here, we have no CMS cases. But if you also look at the numbers of high-risk patients they have, you can see they're very different from the others. On average, you have about a third of the patients fall into the high-risk group, while this center only have 2 to 4. So that kind of reflects what I said before. It could have something to do with the case makeup of their centers, or they could be really well, they could be managing the risk very well. We don't know. We don't have enough sample size for just 2 or 4 to make any firm conclusion. But certainly there's something there. And this is the other thing we talk about, the inter-observer agreements. There are a few things we can do. Say if you look at the tumor sites, certain sites are things that are okay with certain sites, but radiologists struggle with deeper, smaller structures. And that's the thing we need to improve our agreement if we want to roll it out at a different level. So we thought we certainly need to revise our CMS risk assessment tool because we didn't achieve that 50% or above risk that we wanted to say. So we set out and we repeat the analysis following the same approach, but this time we use our much bigger, 245 cases to model that. We follow the same approach. We use both data mining and the conventional check on the statistical significance to shortlist our variables. If there's anything mentioned in the literature that we feel we need to select, we will push it in. But more importantly, this time we add in additional conditions, which we need to achieve reasonable inter-observer agreement. So to ensure that we have a more reliable model, even if that means we need to drop some of the variables and replace it with something else. Because if we can't measure it reliably, there's not much point. Okay, so I'm not going to talk about the final model. We have a few candidates. We go through various iterations, and we think we can achieve about 84 or 85% of accuracy. We can still cluster into low, medium, high risk group, but I think the next step is still far from we can roll out and call it a risk, a product to promote. I think we still need to evaluate at multi-center level again, and also more importantly to test it prospectively. And that's the other things we need to do. Sample size is always crucial. So we work closely with Posterior Fossa Society. Many of them actually are the workshop participants. And also we recruited through various sources. We identified 22 centers across Europe, North America, and Middle East expressed their interests. Okay, so we feel that our preliminary model can confidently identify low-risk cases that will reinforce the surgeon's confidence to carry on with what they're doing. We still need to do a bit of work on the high-risk patients, see if we can push the high-risk group above that 50% threshold. I think the next steps is we want to develop a website training module, because if there's international centers, we can't go out and visit everybody or fly them in to organize a workshop anymore. I think internet is probably the best interface. We've already developed a prototype of training modules. We hope with additional fundings, we can perhaps convert it to a website so that everybody can access it and use it. And more importantly, I think surgical techniques constantly evolve. So we need to continue this data collection, continue this international comparison, and learn from the winner. I think, as I said, the ultimate aim is really to reduce CMS rate, not to predict the risk, not just to predict the outcome. So if we can do anything to learn from the centers developing the new techniques to reduce the risk, that's what we want to do. Okay, so we can have gone this far without our lovely workshop participants. I think we're moving towards the right direction. They're all looking at, yep. So I think that's where we're at. I'm afraid I'm probably not the best person to take clinical questions. I'm sure Professor Walker down there will be happy to answer anything to do with the clinical application of this model. Yeah, thank you very much.